look, I'm getting these really funny heartbeats. Oh, that's anxiety.
Other aspects of lifestyle which may be relevant.
Be patient with yourself and just build up gradually.
So I just needed to have them work with me.
There's a whole bunch of cardiomyopathies.
Benefits of doing genetic testing.
Take their own heart monitor. There's better types of fat.
Try and find a cure for inherited heart muscle diseases.
So I have been given the tall order to talk to you today about arrhythmogenic cardiomyopathy and myocarditis, all within about 30 minutes. So there's a huge amount to cover. I'm not going to pretend I'm going to try and cover everything. There is a very detailed, comprehensive talk that Dr. Savatis gave last year that's online. Some of you may have seen it, or you may have been here last year, and if not, it's on YouTube that you can look at. But what I'm hoping that I'll be able to do in the talk is to cover things that are new and things that I hope are of interest to you. So fingers crossed I chose correctly, but there will be time for questions afterwards. So if there are bits I don't cover that you want to ask me about, please, of course, do. So I thought we'd start by thinking about arrhythmogenic cardiomyopathy and what it is. Now, this is a slide from a paper in 1982, and I hope you can bear with me because I'm going to start with a little bit of brief and recent history when it comes to arrhythmogenic cardiomyopathy. And the reason for doing that is to show you how this is something that we've only really described within the last 40 years. And that may sound like quite a long time, but it feels less like a long time now that it's well within my lifetime. And it's really to show you how things have changed and evolved over a relatively short period of time and how things continue to change and evolve, particularly in the way we think about arrhythmogenic cardiomyopathy and diagnose it. So these early descriptions were of something called right ventricular dysplasia. So it was a condition, and at the very beginning of describing and noticing something, you tend to find people who are very significantly affected by a condition. So they are not the mild cases, they are very much the severely affected cases. And what was seen was that it was the right side of the heart that was affected. And the changes that were seen included changes in the structure and the pump function, so cardiomyopathy, the right-hand side of the heart, but also rhythm abnormalities. These pictures, I apologise if they don't mean a huge lot to you to look at them. The panel on the left is an ECG, which we still use on a daily basis, and it's the first test we'll often do for a patient. The other tests that here, the echo scan, which is the picture in the middle, to me looks nothing like an echo that we do today because technology and advances in the way we can image the heart have moved on so dramatically that this blurry image is nothing like what we're able to see today with the tests that we do, echo and MRI. And the image on the bottom right-hand corner is an angiogram, so it's where they're injecting dye into the cavity of the heart muscle to look at the pump function and to look for any abnormalities in the heart muscle. And we would not do that anymore because our imaging is so much better than it was then. So this was in a time where we didn't know anything about the genetics of the condition. We weren't doing genetic testing, and it was a time that predated CMR, which is the cardiac MRI scans that we perform now. So it's really just to show that it wasn't so very long ago that we first recognised a condition that has evolved to be thought of more as arrhythmogenic cardiomyopathy, but the tests we do and our understanding of it have changed significantly. So I mentioned the first descriptions were of this arrhythmogenic right ventricular cardiomyopathy. So we've talked about heart muscle problems affecting the right-hand side of the heart with rhythm abnormalities as well. And there were certain changes within the heart muscle, if samples of heart muscle were taken, that showed that the heart cells were being replaced by fat and fibrous tissue, which is scar. Now, I will not spend a long time on all of these next few slides, but this is to show how the way we diagnose it has changed serially over time. So it was recognised that there was not just one test that could be done to diagnose somebody with ARVC at the time. And it needed to bring together lots of information from different tests, so electrical tests and imaging tests, but also to think about family history and later on genetics in order to make a diagnosis. And so a group of experts got together in 1994 and created a series of criteria to help make the diagnosis. Then in 2010, they got back together with a few more people involved, and that series of criteria evolved and became slightly better at making the diagnosis. And the 2010 task force criteria, so in 2010, that framework that was created amongst that group of experts is something we're still using today when we think about ARVC. And we use information from various different tests, as we just mentioned. So some of that information is electrical. We get it from ECGs. We get it from rhythm monitoring. Some of it is imaging-based, and we get it from echo scans, the ultrasound scans, and cardiac MRI as well. Increasingly, genetic testing is becoming more helpful for us and for you to make the diagnosis. Family history, of course, there is also very important. It's much less common that a sample of the heart muscle is taken to look under the microscope at the histology, although earlier on in the sort of evolution of looking after people and making the diagnosis, that was done more frequently, which is why it is included in this set of criteria, but it's very rarely done now. We rely so much more on imaging, and I think that the ability of MRI to tell us so much information has taken away a lot of the need to take samples of the heart tissue itself. So all of that early work and early recognition was focused very much on the right-hand side of the heart, the right ventricle. Over time, it became increasingly apparent that this wasn't a condition that just affected the right side of the heart, the right ventricle. It also affected the left-hand side of the heart. And the things that helped us to recognize that, I keep talking about MRI, but it has been so useful in this regard to allow us to see so much more about the heart pump and the function, but also to look for areas of scar tissue fibrosis. Genetic testing also helped us to understand this better. And the problem that was then clear is that the criteria that we were using to diagnose the condition, the ARVC task force criteria I just showed you, focused very much on the right ventricle and didn't include anything within the left side of the heart. So there was a period of time where people started to think about how we extend or revise those criteria to make sure that we consider the same disease process that's happening in the left-hand side of the heart, the left ventricle. And so in 2020, there was another set, so again, no single test, but another set of criteria that was suggested. These modified the last set that focused on the right ventricle and included criteria to help people diagnose the condition when it was found in the left ventricle. Now, those are yet to be externally validated, and so although they are certainly something that we think about and that we keep in mind when we're trying to bring the various bits of information together, as yet, because they're not externally validated, they haven't fed into what I'm going to show you next, which is the latest guidance. So I apologise, that's a very long preamble, but it's really just to try and set the scene for the challenges we have actually in diagnosing what we may now call arrhythmogenic cardiomyopathy, and which I'm going to show you in the next few slides. The latest guidelines suggest we split into the two parts, the right-sided disease and the left-sided disease. It's also to explain why, if you speak to your cardiologists and the diagnosis hasn't seemed to keep track of this, it's because there's been so many changes over such a relatively short period of time. But these new guidelines that were published this year, these aren't just around arrhythmogenic cardiomyopathy, these consider all aspects of cardiomyopathy. There are new ways of describing what we see, which I'll show you in a moment on the next slide, the ones that are relevant to this. And as I said, that's been driven a lot by the information we get from cardiac MRI scans. There's an increased focus on patient pathway, which is obviously incredibly important. There are some new recommendations for how to go about screening relatives, both clinically and genetically. A focus on the fact that these conditions are often genetic conditions, which means there's a lifetime of care. There's some new risk stratification for sudden death. So the increasing knowledge we get about genetics is changing the way we are trying to assess what the risks of serious rhythm disturbances are. I've crossed through this because it's not so relevant to my talk, but there is some updated recommendations for patients with hypertrophic cardiomyopathy, and more focus on the multidisciplinary approach, the fact that looking after our patients involves many different healthcare professionals, and a focus on having the patient and their family at the centre of that care. So, the suggestion in how to describe the condition we're talking about is that we consider everything that is a cardiomyopathy with significant arrhythmia. So that's everything where there is an abnormality in the heart muscle that's associated with significant rhythm changes. The suggestion from these guidelines is that we don't term this arrhythmogenic cardiomyopathy because it's not a distinct condition, but that we consider it like this. Now, on the right-hand side of the screen, we have ARVC, which is what I was talking to you, the condition that was first recognised in the 80s, arrhythmogenic right ventricular cardiomyopathy, and the suggestion is that we think about that in the way that the task force criteria in 2010 that I showed you thought about it. And so when there is cardiomyopathy or heart muscle problem that's predominantly in the right side, the right ventricle, with rhythm problems, that's ARVC. This NDLVC, non-dilated left ventricular cardiomyopathy, is the new term that has been coined in this latest guideline. And this is to differentiate it from dilated cardiomyopathy, where I think Brian is talking about in a different room. But this NDLVC comprises this left-sided ARVC, left dominant ARVC. It's been called ALVC in the past, arrhythmogenic dilated cardiomyopathy. There are lots of terms that were used for it, but it's when the heart muscle problem is in the left ventricle. The heart is not dilated primarily, so the size of the heart remains normal. The pump function may be reduced, and or there may be some scar tissue within the heart muscle, and that's the group, the focus. And I will talk in a little bit more about MRI, and MRI is the most useful test to identify this because it allows us to look at the left side of the heart, it allows us to look to see how the pump is working, and it also allows us to look for scar tissue. I will talk briefly about genetics, and I apologise because I'm never sure how much knowledge you already have about genetics, but it's really just to explain that obviously we all have a different genetic code, that is our DNA, and that translates into various traits or what you see on the outside. And you'll hear a lot about genotype and phenotype. Genotype relates or refers to that genetic code, the DNA. Phenotype reflects what we see on the outside, what that translates into, how we look, and other phenotypic features. There is what we consider to be a normal gene, which is a segment of DNA, or here they're using the term mutated gene. We've moved away from that. We try to think about variation in the genetic code and whether it's normal, whether it's pathological or pathogenic, or somewhere in between. But a normal gene will create a normal protein, an abnormal gene will create an abnormal protein, and that's what then translates into what we see. In terms of understanding genetics, it's a rapidly evolving field and quite a complicated one, I would definitely say. As just said, each of us has a different genetic code in this room. And what the challenge of genetics is to understand what's normal variation, so what's normal and makes us look different and, the differences we all have, and what's abnormal or pathogenic that can cause what we consider to be disease. And so genetic testing, they classify the variants as either benign, normal variation, pathogenic, clearly abnormal, but then there are categories in between that can be harder to understand and we continue to learn more about. This is a very busy slide, and really I just wanted to say that in ARVC, many of the genes that are affected are what we call the desmosomal genes. So it's the genes that create the proteins that help the heart cells to stick together. You can see with the busyness of the slide that there are lots of different genes that are involved, and we are learning more and more about them over time. And there are, as well as the ones that are involved, the desmosomal ones in sticking the heart cells together, there are other ones that influence those indirectly or directly. When we start to think about, and this is where I think the advances in genetics married up with what we can see on the MRI have helped us to understand better, is that in arrhythmogenic cardiomyopathy, which I know I'm not meant to use that term anymore, but if we consider the whole spectrum of disease, there are some genetic changes that are associated with ARVC, right ventricular disease. There are some genetic changes that are associated with the left ventricular disease, and there are some that sit in the middle and can cause changes in both sides of the heart. That isn't absolute, but that's certainly the sort of pattern that we see and that we're learning more and more about. So I hope that it's all making sense and of interest. Is okay, good. Stop me if it's not. I'm going to talk a little bit then next about diagnosis, and I think there's a sort of general approach for anyone that we see in an inherited cardiac conditions clinic who is suspected of having a condition. The first thing to do is to make a diagnosis, and obviously that comprises lots of different things. It's taking a history, so hearing a patient's story, examining, taking a family pedigree, understanding the family context and a family tree, doing at least an ECG and some form of cardiac imaging, and then other investigations dependent upon what you're looking for. Of course, although some people may have no symptoms, many will have symptoms, and so treating symptoms is obviously what we want to be able to do, either through lifestyle, through medication, or through invasive intervention or sometimes surgical procedures. We consider risk stratification for everybody, so it's trying to understand what the risk of significant heart rhythm problems is, so that if there is a high risk of those, we can consider an ICD, an implantable defibrillator, and I will talk a little bit more about that again later on. But of course, with inherited disease, it's not just one person, it's the wider family that are potentially at risk. And so family screening is really important, and that can be done through clinical tests and or through genetic tests. Now, in order for the genetic testing to be possible, we have to find a clearly pathogenic genetic change, or the mutation as it was called before. Because if we find that in the first person that we meet, that we would call the proband, then it's something that we can do to check for in other family members, a genetic test to look for it, to see if they may be at risk. The genetic testing that we do is targeted at the moment very much to the underlying condition, and we look just at the genes that are associated, where there are changes associated in those genes with the condition that we're seeing, if that makes sense. I talked about multidisciplinary care, which is obviously incredibly important, and this is a slide from the latest ESC guidelines, which mentions the vast number of healthcare professionals and allied professionals who are involved in looking after each individual, and the importance that those individuals, as relevant, are involved, but also that they work together to look after somebody and their family. So, clinical features. Here, I'm having just separated out left and right disease, I'm sort of having to mash them back up slightly to talk about the sorts of things that people may experience. So many people will feel nothing. They will have no symptoms. But for people who do start to get symptoms, those may include palpitations, so the feeling that your heart rate is suddenly racing for no reason, the rhythm has changed, jumping around. Some people may have blackouts. If people start to develop problems with the pump function of the heart, we may start to see things like breathlessness develop. And chest pain is something that we also know is associated with arrhythmogenic cardiomyopathy. These clinical courses, the stages of disease, were mapped out for ARVC, the right ventricular disease, because it was noted that it seems to be the electrical changes that happen first before we see structural or pump changes. And in some people, we may never see those pump changes, the heart failure develop. Family history, as I said, is really, really important, and doing at least a 3-generation family pedigree is really helpful to understand a condition. It can help to understand a pattern of inheritance. Here is autosomal dominant, which is where if there is somebody who carries a genetic change, there's a 50% chance they'll pass it to a child. And that's the most common in arrhythmogenic cardiomyopathy, to see autosomal dominant. It helps us to identify who may be at risk. I've just mentioned that many cardiomyopathies, particularly arrhythmogenic cardiomyopathy, will have this pattern of inheritance. Now, I'm going to show you a few tests and try and explain what we're looking for in those tests. But this is an ECG, little diagram for the capture of an ECG, which is just a diagrammatic or a visual representation of the electrical activity in your heart. And what we're looking for is often subtle changes, but it's very uncommon to have a completely normal ECG with cardiomyopathy of all types. And in ARVC, the change that we... Do I have a pointer. I want to mess it up. Oh, I do have a little pointer. The change that we see is here, these T waves, we call it T wave inversion in these leads. And those are the leads that are overlying the right-hand side of the heart, the right ventricle, so it tends to be where we see some changes. In the left ventricular disease, we tend to see changes in the ECG leads that are lying over the left-hand side of the heart, the left ventricle. And on the ECG here, we see T-wave inversion, but over the lateral leads and the inferior leads here. So there are certain changes in the ECG that aren't going to diagnose a particular condition, but they're going to give us clues about what might be going on and help us to work out which other tests are going to be helpful. And the pictures on the right-hand side there are from an MRI scan corresponding to this ECG, which shows the black circle and the black kind of semicircle is the left ventricle, the muscle, and black is normal and white is scar. So where we see little bits of white encroaching on the black, that's where the scar tissue is. Other tests that we do include rhythm monitoring. So the ECG only gives us a snapshot of electrical activity. Longer monitors are necessary often to capture rhythm abnormalities. This is on the ECGs before, we saw nice gaps between the electrical complexes. Here we see very rapid heart rates, which indicate here. So this is a patient who's had ventricular tachycardia, VT. So cardiac MRI, I feel a bit like a broken record, but this has been so helpful, I think, in understanding arrhythmogenic cardiomyopathy better. It uses magnetic fields to build up images of the heart, which is great because it doesn't give any radiation with that. My slides have been a little bit unpredictable in their videos, but it's playing. So you can see the heart, a normal heart there. We have the left ventricle, which is this side, where the muscle is thicker, and the right ventricle here. And these bits, that's the right atrium, and that's the left atrium. So the main pumping chambers here, the ventricles. And you can see that the MRI gives us a really beautifully clear picture. We can look at the heart in lots of different ways. So we can plan the study so that we cut through the heart in different planes so that we can look at it from all angles. There are standard planes like this that will be chosen, but if you see something while you're doing the scan that needs a little bit more, that you want to get more information about, you can change it as you're doing it. So really this is Cine-Imaging, just to show how much detail you can get from the MRI scan. And then in particular, the importance of the what we call the late enhancement imaging. We give a dye called gadolinium, and that clears very quickly from normal heart muscle, but it hangs around for longer when the heart muscle is scarred or abnormal. And so what we see is, rather than the black, as we said before in this imaging, the black muscle is normal, the white represents fibrosis or scar, and different patterns that we see on the scan can help to give us more information or clues about what the cause is. So in terms of coming back to ARVC, and I will come back to NDLVC in the next slide. In ARVC, we're looking at the right-hand side of the heart, the right ventricle, and here we can see, these don't play, I'm afraid, but the right ventricle, which is here, there are some little outpouchings, which are described as aneurysms, which become more prominent when the heart muscle is contracted. So this would be the Cine-Imaging that we saw. I apologise, it doesn't play. But on the other side, this is the scar imaging. So the white areas, as we said, represent fibrosis or scar rather than the black, which is the normal heart muscle. When we think about NDLVC, I'm still getting used to saying it, but the left ventricular form of this condition is obviously the left side of the heart that we're interested in, and we're looking for similar changes. We're looking for changes in the function of the heart, so reduction in the pump function, and also the presence of the scar tissue, so the white sitting within the black. And there are different patterns that seem to relate to different underlying genetic abnormalities. But this pattern where we see almost a ring of white is fairly characteristic of certain genetic abnormalities in 3 genes that are listed there that are associated with arrhythmogenic cardiomyopathy. So why do a genetic test? You know, and a genetic test is something that people should be counselled for, and it's a decision for them to make whether they would like to have a genetic test or not. The genetic testing, however, I think is becoming increasingly useful in that we know in some circumstances it can help us to firm up a diagnosis. And by doing that, it can help us to be a little bit more, a little better able to give prognosis, so information about how the things may change over time. Increasingly, because of all the focus on understanding genetics and creating treatments that are targeted to particular genetic changes, there's already some treatment that can be guided by what's found if there's a genetic abnormality found, and I think increasingly there will be more and more of that. It can also be helpful to have a genetic diagnosis when you're thinking about starting a family. And we mentioned already how it can be used to look at other members of the family to see if they're at risk. I hope I'm not running out of time. I'm going to talk a little bit now about management, and when we say management, so treatment. When we think about arrhythmogenic cardiomyopathy as a whole, there are lots of things to think about when it comes to treatment. I'm not going to go into detail for all of these today. I'm showing this slide, it's busy, just to show that there are lots of things to take into consideration. We'll talk a little bit in the next slide more about exercise. In terms of heart failure, for those patients who develop heart failure, there are many treatments available, initially medical, but other therapies. We need to think about treatments for rhythm problems. We sometimes think about something called catheter ablation, and for some people we need to think about blood thinning medication. That's a very brief overview, and I'm going to go into a few of those in a little bit more detail now. Apologies, not time for all of them. But I think exercise is something that I know you're going to have another talk later. I think Helen Alexander is coming to talk about exercise in more detail. But it's something that in arrhythmogenic cardiomyopathy we think about in particular. Now, there are guidelines that the European Society of Cardiology wrote, or an expert group wrote in 2020, and then there's some information in this latest cardiomyopathy guideline from this year. I think in general, when we think about ARVC, we know there is evidence to suggest that high-intensity exercise can cause the disease to progress. And so in people who have the diagnosis of ARVC, we do recommend against intensive exercise and competitive sports. There's a little bit less evidence about people who carry the genetic change but don't have any signs of the condition. And the 2020 guidelines would have said that those people should probably be counselled to avoid the high intensity and competitive sports. This latest guidance has said that the evidence is less clear here. And it does seem that mild to moderate exercise, up to 150 minutes per week, it seems safe. So it's trying to strike that balance always between you don't want people to sit and do no exercise because that has implications that can be bad for your heart or your cardiovascular health. But at the same time, you want to strike a balance where there's not such high level of exercise that you could be exacerbating the condition. For the left-sided form, it's a little bit less clear that exercise is contributory to the condition. The advice is that in people who have symptoms should avoid high-intensity exercise and competitive sports. But if there are no symptoms and if the risk is low, most competitive sports do seem to be okay. And in the gene carriers, there's nothing to suggest that high-intensity and competitive sports should be avoided apart from these three. So lamin, one called TMEM43, and filamin C. So this is where, again, perhaps having a genetic diagnosis is helpful in terms of just tailoring what we do. Beta blockers, I won't spend long talking about beta blockers, but beta blockers are the first-line treatment, and these can reduce the arrhythmias, the heart rhythm disturbances, particularly during exercise. And that's because they block that fight or flight response that all of us have, the adrenaline that creates that. And there's many, many, many different types of beta blockers, and they broadly do the same thing, but they do sit in slightly different classes. And the reason I mention that is that it may be that somebody has a side effect with one, but it doesn't mean it's necessarily going to be the same for all. So I think it's always worth trying another if you are somebody who does have side effects. Catheter ablation, this is, this applies to a very small number of people. This is for people where they're getting lots of rhythm abnormalities despite medication. And this is a procedure where wires can be fed up to the heart to find out where those rhythm problems are coming from, and a little bit of energy delivered to a small area of the heart tissue to try and break the circuit, essentially, to try and take the rhythm abnormality away. Now, I think that this isn't a substitute for what we're going to talk about next, which is an ICD. It's a way of controlling lots of rhythm problems. It doesn't seem to alter the risks associated with the rhythm problems, but if the medications aren't doing it alone, this is something that can be thought about. So, when we're thinking about ICDs, what we're always trying to do is balance risks. And we are not perfect at understanding what the risks are. And when we talk about risks, we're talking about serious rhythm problems that could cause collapse or cardiac arrest. It's clear that in people who have survived a cardiac arrest or who have significant rhythm abnormalities, an ICD is the right thing. And we call that secondary prevention. In people who haven't had a problem, we're always trying to understand what the risks of developing a problem are and who would benefit from an ICD. And there's lots of change happening here. There are risk calculators that people are creating and lots more information that can feed into the decision-making process. I'm not going to go into lots of details about it, but from to say that I don't think it's one size fits all for anybody. It needs to be an individualised approach. MDT discussions, which is multidisciplinary meeting where lots of specialists get together, are very helpful here to bring knowledge together and to make a plan. But then, of course, that plan, we talk about shared decision making, and I think you're going to hear about that later, in terms of a plan that is discussed between doctor and patient to come to the right thing for them. I am running out of time, but I will just hopefully mention a couple more slides and then stop. An ICD there's a diagram of one here, the defibrillator. It's a small battery-powered device. Usually there are wires that pass into the heart, although there are new forms where the wires sit within the chest wall. There are various, even newer types being developed, which are called leadless devices, where there will be a little, the box will still be here with the battery, but a little electrode that sits within the heart muscle without a wire connecting the two are coming. They're not quite here yet, they're coming. The reason that they can be helpful is that over time there can be problems with the leads. Leads can wear like anything over time. But this device is helpful because it's constantly monitoring the heartbeats. It can treat slow rhythms, it can treat fast rhythms, but it can have its own complications, and that's why it's not a universal one, fits all. It's trying to balance the risks to work out whether it's the right thing to help. I have just a few slides on myocarditis, but if you would prefer to stop now and do questions,
can we take questions?
Yeah.
And if anyone's got a particular myocarditis question, then we can pick it up at that stage, if that's okay.
Absolutely.
So, Rachel, thanks ever so much. You've done so well to cover such a lot in what is a relatively short time, of course. Can I invite questions from the audience? Anyone got anything they'd like to ask? Yes.
How important is it for patients to be aware of the distinction between the left and the right side of diagnosis in terms of being kind of like active in their kind of care going forwards and understanding disease progression? Because I've been newly diagnosed, but I don't know what side it is. And it's only, I've looked at the MRI and it's like, it says something about the left side, so I'm assuming it's on the left, and I've got the desmoplakin gene variant, so I'm assuming,
so, I think it's still a rapidly changing and evolving field. I think that this distinction has only really been crystallised in these guidelines that were only published a few weeks ago, in all reality. I think as things sit at the moment, for the vast majority of your care, it doesn't make any difference in all reality. However, I think that will continue to evolve and change. And like we just talked about a little bit there with the exercise recommendations being slightly different for those who have right-sided ARVC, predominantly right-sided disease, compared to left-sided disease, we're beginning to see that evolve. And that's the broadly speaking, thinking about the left and the right. But I think that now a genetic diagnosis isn't possible for everybody. We know that not everybody who has the condition will find, we won't always find the genetic reason for that as things stand. Again, that continues to change. But I do think that it's probably going to come down more than just left versus right. But if it's possible to understand the underlying genetic abnormality, that will help to refine understanding and treatment even more. We mentioned, the left-sided disease when it comes to exercise. There are a few genetic abnormalities where we would still say it's a good idea to not do the competitive sport, to not do the high-intensity sport. So I think this is changing in a good way. I think we're learning more and more, and we'll be able to give you more tailored advice and treatment as the next few years pass. As you can see, it's come a long way in a short time. I mean, I think as things stand right now, not major differences, but helpful to begin to understand that for you from your MRI scan, and dependent on whether you're going to have a genetic test and have a genetic diagnosis as well. Those will be increasingly helpful for the future, I think. Does that make sense?
Thanks, Rachel. More questions?
Thank you. Thank you very much for a very interesting lecture. I have a question about genetic screening. On what age do you start? Do you screen children, for example?
So there is some advice around this actually in the new guidelines. I will admit at the beginning here I'm an adult cardiologist, so I tend to, the patients I look after are 16 and above. In terms of genetic testing in children, I think it's always been shied away from. Not always, but largely shied away from. Because the children are unable to make the informed consent themselves. But I think that there are some situations where it is helpful, and I think there's now new guidelines around navigating that. I think certainly children who are born with a significant heart muscle problem cardiomyopathy, genetic screening is often performed for them with quite a reasonably large panel of genes to try and understand that as quickly as possible so that you can give that child the best treatment to give them the best, outlook. In children where they don't have any condition but parents do, where the genetic change is known in the parent, that's a little bit more of perhaps a time where there's individualized approaches. And in the past, often it has been shied away from testing the child because you may worry about how that impacts their outlook on life, if you like, and how they are as a child and in their childhood. But I think there is some increasing, particularly with the genetic abnormalities where we can intervene, knowing about something early is the right thing to do. I think if it's not going to change how you look after the child, it's probably less necessary, and you can leave it until later, until they're able to make that decision themselves. But the way I'm beginning to think about it more is that if a genetic test could help you to change how you look after that person and therefore change how things progress for that person, then it's a good thing to do. There is sort of more advice around it in the recent guidance.
Rachel, thank you. I'm conscious we're running a little bit short on time, but one final question.
Thank you. Thanks, Rachel. That was a really nice talk. I was more genetics. I was diagnosed on the basis of a PKP2 genetic test, but probably about 10 or 12 years ago now, and I was wondering with the changes in genetics since then, if it's worth having another test, if more genes would be brought up. And following from the previous question, both my children also tested positive for PKP2, so I'm kind of interested in that.
Yeah, no, for sure. And I think, reassessing genetic changes periodically is really important because of the way things change and how we understand it. I think if you have a clear genetic diagnosis, there's probably less reason to repeat a test, because providing that there hasn't been any change in whether that's clearly pathogenic, which you would assume not, but you can always check with your cardiologist to just make sure, because sometimes these genetic changes are recategorized over time. But providing that is the case, which you would assume it is if your children have had the test as well, then there's probably less reason to repeat the genetic testing. I think for people who who had a genetic test 10, 12 years ago where there wasn't a genetic abnormality found, the genes that we test have increased, and we have more understanding of other genes that we didn't know about at that time. So for people in that situation, I would definitely say it's worth revisiting if the first test was 10 years ago.